Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really fascinating guest today, helping to create a better tomorrow for many people. Today, we have the honor of being joined by Dr. Robert Montgomery, who is director of the NYU Langone Transplant Institute and chair in the Department of Surgery, where he oversees a diverse team of medical and surgical specialists that provide a wide range of surgery and transplantation services, including those for bone marrow, heart, kidney, liver, lung, and facial transplantation. Dr. Montgomery received his Doctor of Medicine with honor from University of Rochester School of Medicine, his PhD in Molecular Immunology from Oxford, and he completed his general surgical training, multi-organ transplantation fellowship, and postdoc fellowship in human molecular genetics at Johns Hopkins, where for over a decade, Dr. Montgomery also served there as Chief of Transplant Surgery and Director of their Comprehensive Transplant Center. Dr. Montgomery was part of the team that developed the laparoscopic procedure for live kidney donation, a procedure that's become standard throughout the world. He and his team at Hopkins conceived of the Hopkins protocol for desensitization of incompatible kidney transplant patients, the idea of domino paired donation kidney swaps, and he's performed the first chain of transplants started by an altruistic donor, leading teams that performed two-way, 3, 4, 5, 6, 8, and 10-way paired donations and open chain donation. Dr. Montgomery currently has a research focus on a range of areas, including stem cell therapies, gene and cell-based therapies in transplantation. He was recently co-leading clinical trials sponsored by the NIH involving simultaneous donor bone marrow and live donor kidney transplantation. He also runs multiple clinical trials for novel desensitization therapies. And in addition to a wide range of accolades and awards received, he also is credited in the Guinness Book of World Records with the most kidney transplants performed in one day. And on top of all that, he is also a transplant recipient himself, so he's a very unique perspective from both that of a clinician and patient. We're honored to have him with us today. Dr. Robert Montgomery, thank you so much for taking time out of your schedule to come talk to us.
Thank you, Ira, and thanks for that nice introduction.
Yeah, it's great having you. Obviously, the last several months have been quite busy for you, especially in one really hot area, that of xenotransplantation, which we've seen you all over the press. A couple of months ago, we had David Cooper on from sort of Mass Gen, sort of laying out the last couple of decades of the development of xeno. But you have been at the forefront of the first in terms of the going into humans with some of this clinical experience. I saw, just last week, actually, in Nature Medicine, you published a piece, Next Steps for Xenotransplantation of Pig Organs into Humans. Can you take us just on a little bit of your perspective from the last several months? Did you expect xeno to get on the scene so fast, looking back now in history, and then just a little bit of the learnings from sort of a lot of things going on over 2021 and into the current year.
Sounds good. So, yeah, I mean, look, we definitely are standing on the shoulders of giants like David Cooper and the people who have been working very hard at this for, decades now. You probably know that up until very recently, all of the breakthrough work that had been done in xenotransplantation really had been done in primate models. So these are, monkeys that are receiving genetically modified pig organs. And again, there's been probably more than 30 years of studies in primates that really provided the background work that led to these recent developments in the clinical application of xenotransplantation. So for about 4 years now, we've been working on this concept that there is an intermediate step between the primate research that's been done and the first in human, living human studies that we're all anticipating, where that giant leap that would be required to take this very complex technology from animal studies to living humans could be bridged. And that idea was to attempt, in these kinds of high stake studies, to test the whatever is of interest, in this case a pig organ, in a recently deceased human. So you could essentially fail safe if there were some untoward event that occurred. The recipient, in this case of the xenograft, was already dead, and so the impact obviously wouldn't be the same as if it were a living human. And it would, in my opinion, in thinking about this when we really started on this journey 4 years ago, give us the needed confidence that this would work in living humans, that could tip the balance, because we've kind of been at this stage of becoming better and better monkey doctors, basically, to try to perfect this in a imperfect model. Primates are very fragile. They have some complicated physiology and genetics that actually makes transplanting a pig organ into them even more complex than a human. And studying primates for long periods of time with pig organs is very expensive. And again, they just seem to to succumb to things like dehydration and infections in a way that humans just don't. And so I think actually it's given us a more pessimistic view of what the possibilities are for xenotransplantation in humans. And so, testing these in someone who had been declared brain dead, who had wanted to donate their organs, but for some reason their organs were deemed to be unsuitable for donation, then would essentially donate their body for the purpose of a study of, in this case, xenografts. Although it's not, this concept is not necessarily limited to testing pig organs. We also have intentions of testing bioartificial organs, or organs that are produced by 3D printing, or a process where an animal organ is decellularized and then recellularized with human cells. That's a separate topic, but just to point out that the recently deceased, studying these kinds of again, high stakes innovations as an intermediate step between animal studies and human studies, because we've seen a lot of things either not work in animals or work in animals and then not work in humans. And at the end of the day, the best way to test something that your intention is to take into the clinic and to use as a breakthrough therapy for humans is to test it in humans.
Yep. Speaking of the living cadaver model for a minute, because I also noticed that quite recently you published in, I think it was the Journal of Thoracic and Cardiovascular Surgery, also about your experience with another sort of really cutting edge area in this space in terms of heart transplantation in a model of donation after circulatory death, not brain death. And I know there was a little bit of back and forth. You and Art Kaplan and the American College of Physicians were going at it a bit there. But the combination of, okay, we don't have a brain dead subject yet, but we're close to that. And this is a very critical period. You have novel capabilities now, enhanced knowledge with regard to how to reperfuse organs better than we ever have. Talk a little bit about what's been happening on the donation after circulatory death front.
I mean, I think that's that is a great example why it's so important to develop another source of organs that doesn't include this old paradigm that somebody has to die in order for somebody to live.
Yep.
Because there's a lot of controversy now and really what defines death.
Yep.
And that's really, without going into a tremendous amount of detail in this, somewhat of a new riff on what's called a donor after cardiac death, which you referred to, NRP, that, surprisingly has become another area of controversy, again, in this, spectrum of between living and death that at times gets questioned, and there are ethical arguments, about when death has actually occurred, and the technology that has allowed us to do things like put people on cardiopulmonary bypass, or what's a procedure very similar to that called ECMO, and potentially rescue them from death when they've had a cardiac arrest. Now, this is an area of great interest to me because I've had 7, potential cardiac deaths that I've been resuscitated from. And when you think about it, CPR was developed in the 1960s, and there's been no progress in trying to resuscitate somebody who has died. And sadly, we're still at a point where only about 10% of the people who have a cardiac arrest in the hospital are able to leave the hospital. And so there's increased interest in how do we resuscitate people? How do we try to resuscitate the brain too? And, is there, technology now that's out there that would allow us to reanimate the brain? So there's going to be a tremendous amount of controversy as some of this technology gets developed. And you probably remember hearing about the Yale group in 2019 when they were able to get some type of neuroactivity from a pig brain that, basically had been without circulation for 4 hours. And again, all of these things, and many things that I've been involved in my whole career that you mentioned in the introduction, were all about trying to increase the number of donors that could be available to, prevent the death on the wait list that is such, it's the #1 unmet need in transplantation right now is organ supply. And only a third of the people who get listed for a life-saving transplant ever make it across the finish line. And so we've got a system that, we've been working on trying to improve, but it's kind of a broken paradigm, in my opinion, and that's why things like xenotransplantation and bioartificial organs become so critical, because they are, if you will, the wind and the solar of the organ supply. They're the future. They're sustainable ways to provide an unlimited supply of organs for humans, and to prevent this needless death that occurs on the waiting list, which I could have easily succumbed to. In a way, I'm sort of, a one in a million example of someone who was able to sort of go through that gauntlet, having all these cardiac arrests and being resuscitated. And it was only just by luck, because I happened to have a nurse and a doctor at one point who were with me, at a Broadway show when I had extended CPR. And it was only because they were so good at doing it that I'm here today talking to you. And, we can't be in that position where so many people are dying waiting for organs. So there's a lot of controversy, in what we're currently doing to try to enhance the organ supply. I personally think it's kind of, in a way, controversy that is sort of being started by non-combatants, who are people who are really kind of not in the fray, but still, it's out there, and we have to address it. But boy, to my mind, the best way to address it is to not have to rely on, some of these innovations that are kind of, pushing us further and further out on these edges of, what the ethicists will argue one way or the other, and to really just break through into an entirely new sphere where, we're really dealing with more than one source of organs for transplantation.
Yeah, I completely agree with you. That's why, whether we're talking about Xeno, or, I've had folks like Tony Atala on talking about bioprinting, and Doris Taylor, who's been a friend of mine a long time on the D-cell resell front. I think all of these venues are just so important to, in lieu of that, though, hopefully they get here sooner than later, but you've been equally, aside from sort of building up this amazing clinical experience, you've been also working extensively on, what we'll put in this desensitization basket, desensitization therapies, everything from novel monoclonal antibodies. You've published on splenic irradiation, and then, as I mentioned in the intro, you paradigm, this new paradigm of transplanting bone marrow along with an organ. Talk a little bit about where we are on the desensitization front. What gets you excited? What technologies are hot? What you're not that interested in anymore?
So just, for the audience, desensitization, really what it involves is, there are essentially two, important types of incompatibilities that would prevent a donor from being able to donate to, a recipient. And one of those incompatibilities is blood type. So we know that there are certain blood types that cannot, receive an organ from another blood type. And the reason why they can't is because they have antibodies against that other blood type, basically. So it's all about antibodies when we talk about incompatibility. Same thing with xenotransplantation. It's antibodies that we have against, in xenotransplantation, sugars that, were lost during evolution, that are expressed in pigs but not in humans, and we have antibodies against those sugars, because we tend to make, an immune response against things that are not self, that are not, part of us. And then the other major type of incompatibility in allotransplantation, or transplantation between two humans, aside from ABO incompatibility, is due to exposure, previous exposure to other people's tissue. So how could that happen? Well, it can believe it or not, can happen during pregnancy because there's some, leakage through the placenta. And so the baby is half mom and half dad. And so mom gets exposed to that half that, is dad and can mount an immune response to that. Now, it doesn't really have much effect in most cases with the baby, but if then mom needs a transplant at some point in the future, she could be, incompatible with her donor. Another way is if you just get a blood transfusion, there are cells aside from red cells, white cells that again are foreign tissue, and we can develop an immune response. And then more and more now people are getting second or third transplants. And so that's a source of incompatibility. So when I first started being interested in this in the 1990s, there was nothing really that you could do with somebody, particularly who was sensitized to other people's tissue. And there's various degrees of sensitization, but the people who were really sensitized to other people's tissue, they were just sitting on transplant lists for decades and never getting an offer because every offer they potentially would get would be incompatible. And so this was a completely disenfranchised group of people that, the number of those individuals on the list has changed, and it has to do with how we define them and the sensitivity of the testing. But, it's somewhere between 5 and 10,000 people who are waiting for a transplant have a significant degree of sensitization, and this limits the possibilities of them getting an organ. So there's two ways to get around that. You can either directly address the sensitization problem, which is the antibodies that person harbors, against other people's tissue, and try to remove those antibodies. There's various ways to do that. You can remove them through a process called plasmapheresis, where you put their blood through a machine that basically cleanses the blood from those antibodies. Another way to do it is to, if you are lucky enough to have a living donor and you need a kidney, is to do a swap. So you swap with another pair who also has an incompatibility, either blood type or sensitization. And if their donor is compatible with you and your donor is compatible with them, you can just swap kidneys. Or, as you mentioned, we do these long chains now that are of these paired donations. And actually, there are 1,000 transplants every year, living donor transplants, that are done by kidney paired donation. This little idea that we came up with in the early 2000s, we had no idea how impactful that was going to be, is now responsible for 1,000 transplants a year. Having said that, sadly, the number of living, even though we added 1,000 transplants that wouldn't have happened every year, the number of total living donor kidney transplants has not increased. So there's actually been fewer compatible living donor kidney transplants. And we don't know why that is, but that's, again, a vulnerability, one of the other vulnerabilities that we're facing now with this organ supply. Sadly, the only really significant impact that we've had on the organ supply in the past decade has been the result of the opioid epidemic. Last year, there were 107,000, mostly young people, who died of drug overdoses, if you can believe that, in the United States. And many of their families, in that horrible moment of despair, were willing to donate their loved one's organs, or they had said, in life that they wanted to donate their organs. And so we have been able to make use of many of those organs. And one way that we really increased, and you may know that that's how I got my heart, the number of those drug overdose victims who are able to donate is by using hepatitis C organs, because 25% of the organs from drug overdose victims have hepatitis C. And so I took a hepatitis C positive heart, and then took the drugs. We now have very good drugs for hepatitis C, and for 2 months, and I contracted hepatitis C, but then it was completely eliminated by these drugs, and so we've been able to make good use. But hopefully, we spent over $50 billion last year on addiction therapy and research. We're going to have the equivalent of the airbag, hopefully, at some point, that really changed everything in terms of death from motor vehicle accidents. And what we've seen is number of donors from motor vehicle accidents has gone way down, but drug overdose victims has gone way up. But at some point, with what we're doing, to try to prevent that, hopefully, we're going to turn that around. And again, then, the shortage of organs is going to become even more dire. And so all of these things are constantly swirling in my mind. I've been in those shoes of having to sit and wait and wondering whether an organ was going to come in time. And during those many days and years when I knew that I was going to need a transplant, but wasn't quite sick enough yet, I thought about these things, and constantly thinking about how we need to, face these challenges and to, diversify our organ supply, much the way we're thinking about global warming and energy and getting away from, fossil fuels, and having other options. And that's the way we have to think about the organ shortage as well.
In the bio, I mentioned that you aside from the stem cells and some cell-based therapies, you also have a focus on gene therapy, and we've done a couple episodes lately on just sort of the history of gene therapy and how we're getting into a point now where things are getting back to normal after sort of a lag there. Any interesting gene therapy related technologies? I know we use some of these gene therapies to modulate the histocompatibility of some of the xeno stuff, but anything you're seeing that looks interesting on the gene therapy front in terms of dealing with very incompatible organ donors and after transplant?
So not specifically gene therapy, but there's a new technology that is looking very promising on the incompatibility front for ABO incompatibility, which has to do with the treatment of the donor organ prior to transplantation. And in this case, there are people who have thought about genetically modifying, the organ before transplantation, what we've done with pig organs. But one thing that a technology that has recently been developed can basically enzymatically remove the blood type antigens from the organ by perfusing, this enzyme through the organ and make every organ blood type O, so the universal donor. Because there are certain blood types that are really hard to match because of incompatibilities.
Sure.
And so, essentially by perfusing the organ before transplant, removing those blood type antigens that are expressed on the surface of the cells and organs, you can make every organ blood type O, and could be used in anybody. So that's one interesting thing. Now there are, people who are looking at genetic modifications, of human organs prior to transplantation. For my family, one of the reasons that I became very interested in gene therapy back in the 90s, even before we knew what the gene mutation was that's involved in my family that causes heart disease and cardiomyopathy, and why I had to have a heart transplant, why my brother had a heart transplant, why one of my other brothers died, and why my dad died. It's all from the same genetic disorder. it's a mutation. It's a very simple mutation. It's sort of like, if you think about a phone book, there's one phone number in the entire phone book that's wrong. I mean, I know, but nobody thinks about phone books anymore. But we used to have phone books, right?
Used to have them.
They were gigantic, and they used to come to your house. And
Yeah.
I remember carrying those things in, every phone number. And so you could think about with CRISPR technology going in and changing the digit in that
Yeah.
one phone number that made it wrong. So I've had a tremendous interest, because of my family and what we've been through in gene therapy, and spent time working on a gene therapy solution for a disease called Marfan syndrome.
Yep.
And in coming up with strategies that potentially back then I hadn't even really discovered our mutation, but we know it now. And there are some companies that are interested in it, and I've been approached by companies that are interested in the decedent model as a way of testing gene therapy. Again, another example of sort of a high stakes type of complex technology, that where an intermediate step between the animal studies and the living human studies could be really critically important in terms of safety.
Absolutely.
So I have a lot of different strings in my life that have all kind of come together in weird ways, and that's one of them. And I try to focus in my research on things that are important,
Yep.
important to humankind, but also important to me and my family, quite honestly. And those things are constantly on my mind, and coming up with new solutions that are not obvious or out there right now, is what I constantly am thinking about.
Yeah, but I mean, you're the right person to think about them, because ultimately, you're the bridge between the technology and the patient. So I mean, the fact that you do think of these bridge tools, whether the living cadaver research or CRISPRing, and no, it's a wonderful story. Robert, one other thing I just want to ask you about, because I was watching it before, in the NYU Langone video. There's a couple of minutes or a little commercial that you're involved in, and one of the things you mentioned in there is robotics, and that we're not at the point where we have the heart transplant robots or the kidney transplant robot yet, but robotics are going to be a part of this thing in the future. Just say a few words about some of the sort of the non-biological tools here as well.
Sure. So robotics, in surgery, you'd be surprised how many operations now are done, using robots,
Yeah.
With a surgeon at a console, not at the bedside. So there's always somebody, next to the operating room table who's, assisting and helping to change instruments and things like that. But the surgeon is in another part of the operating room sitting at a console. Mm-hmm. And there's no reason why, once we have lots of like low-level satellites and, ways of avoiding, delays and in that you always see on TV when someone's asking, when a news reporter is asking somebody a question in Ukraine, there's this delay, and that's problematic in surgery. But, I think there are ways that we're developing technologies to eliminate that. You could be kind of anywhere in the world, just like drone pilots, and doing operations, right? So I think, that's not too far away, where probably, I could be in my office helping to teach, robotic kidney donation surgery to surgeons in China. So that's been a really exciting development. It's less invasive. It's it actually, you can see things even better than during an open operation. But there's also going to be, tiny little devices and, robotic devices that we're going to, in the future, insert into people. And, to either measure important parameters that, we're unable to in real time. I mean, I think about myself. So I was the first surgeon in the world to get an implantable defibrillator back in the 80s. And, we thought it was the end of my career because there was a tremendous concern that just the devices that we use in the operating room that generate electrical noise would cause the device to go off. But we overcame that and found that that was not the case. But the original devices, were, the size of a Coke can, or and had to be. My first device was implanted in my abdomen, and I had to have my chest open. And the technology then was, so new, and now it's been shrunk down to, basically the size of a silver dollar. And now, a couple of my kids have defibrillators that don't even have leads. There's no connection to the heart. They just implant it underneath the skin, subcutaneous tissue. And so if you think about, the technology and how it's developed, and just in my lifetime and just for my particular problem, it's just mind-blowing. I mean, it was so limiting back then. And now, probably you've come in contact with somebody during your day who has a defibrillator, probably. They've become so prevalent. At least, most defibrillators now are pacemakers and defibrillators. A lot of pacemakers have a defibrillation, option. So these devices, and I think similar to that, we're going to be, of course, everybody knows about Neuralink, and, the idea that things can be inserted in different parts of the body to either affect a change or replace something that is not functioning, or to gather information, right? Or to download information. So it's an amazing, exciting future that we're going to have to, really think hard about and navigate. But I think with xenotransplantation and being able to replace organs when they wear out, and research that's going on, the deterioration of the brain and maybe augmentation there, the lifespan of humans, I think, is going to really, extend tremendously. And I do envision a future where we can replace things. Again, but we can't be dependent on other people dying in order to do that. We've got to replace them with something that's renewable. Absolutely. And so what we're working on now is just a small part of that future, but it's I think an important one.
It's a major part of it, actually. No, it's so impressive. I mean, I agree with that, with everything you said too about how positive it's all looking. Robert, one last thing while I have you, because you just mentioned in the example of the Ukraine, can you say a few words about your recent medical missions to the Ukraine? Because they've been active over there.
I'm getting ready to go back there. I mean, again, like I would say that ever since I was a young a kid, I've always, I don't know, been drawn to things where I thought there was some injustice or some need for something to be cared for. That's kind of been a theme throughout my life. And And, I think what's happening in Ukraine is just, it is just uh, something that is really very difficult to even imagine, in the modern day, that, um, a sovereign country for no good reason is invaded, and people are killed, in unbelievable numbers. And I immediately, felt when, in February, when this happened, this incredible injustice, that I was just drawn to try to go there and do whatever I could to help. And so I took my first trip in May without, kind of a sponsoring organization, just a friend, a colleague who's a nephrologist, transplant nephrologist in Poland. And he and I met in Poland, and then took, several trains and walked for a while. We had backpacks, and had contacted, the largest transplant group in Ukraine, in Lviv, and we met up with them, and we spent a week doing transplants, in their hospital. There, you can imagine that the vast majority of doctors in Ukraine now are working on trauma and casualties, and these horrific injuries that the civilians, the children, the soldiers have had. I saw just unbelievable things walking through the ICUs, people who were just completely broken physically and mentally, from this horror. And so, sort of like in the beginning of COVID, when all the medical care attention is being directed towards one thing, everything else suffers, right? So there's a need to try to continue to do the other things that are important, like transplantation, like cancer care, so that people aren't needlessly dying. So, we worked with this incredible team of surgeons and physicians in Lviv, and did transplants. And then when I got back, I have worked with some wonderful organizations, and we've raised money, and we've got a shipment of equipment, operating room equipment, that we're sending over. And then I'm going to go back in October, and do some more work there. And it's one of the most fulfilling things I've ever done. And it's, it's become such a big part of me now. And I think about my friends there and what they're going through. They're all living alone. They don't, they've sent their families to other countries. And we have this app on our phones when we cross the border, and it locates, you put your location in, and it draws a circle around you. And if there's a missile launch, this alarm goes off. It, like, basically makes you fall out of bed. It's so loud. And you have to go to a shelter. And this is what their people are living with, day to day. So it's something that, has really gotten into me in a deep way. And I'm hoping to be able to do whatever I can to continue to help the people in that country.
I appreciate you sharing that, and it's just so inspirational, Robert, just hearing all of your story. I mean, just everything you're involved in on all these fronts, and I just really wish you the best with all of it, as you continue to push forward on these boundaries, as you continue to help so many people, not just here in the U.S. but abroad. Really an amazing story. Um, for everybody that is going to be listening to this particular episode of our show across the various podcast networks, or watching on our YouTube channel. Again, you've been listening to Dr. Robert Montgomery, Director, NYU Langone Transplant Institute, Chair, the Department of Surgery. Robert, again, I want to thank you for taking the time out of your very busy schedule to come talk to us for a little while and educate us on these topics. Obviously, thank you for everything you've done and continue to do for humanity. And as we say on our show, thanks for helping to create a better tomorrow for so many people out there via what you're doing. It's such an inspiring story, and I really appreciate your time.
Thank you, Ira, and thanks for having me. I really appreciate it as well.